Hello, India. I'm Stephen Hohmann, vascular surgeon from Dallas, Texas. First of all, I'd like to thank the organizers for Avatar for having me. Very excited to be here today. Wish I was with you guys in India, but I'm very excited to tell you about the Wavelinq endovascular AV fistula system. I'm Stephen Hohmann, vascular surgeon in Dallas, Texas. Here's my contact information. If anyone needs to reach out to me, please feel free to do so. I am the program director for our vascular surgery fellowship and have been interested in working on the Wavelinq since its FDA approval in the United States in October of 2018. For disclosures, I am a consultant speaker for BD, as well as the slides being courtesy of BD as well. Well, let's get into it. Here's an animation of the actual procedure. So it's a 4 French system, 2 catheters. Here's the generator, and the catheter on top is the venous catheter. That's one that connects the generator, and then the arterial one. Here is 2 sheaths, one in the brachial artery, one in the brachial vein. Here we're bringing the arterial catheter into position. That has the ceramic backstop. Then here comes the venous catheter, and this has the electrode. Then you can see the magnets join them together. Here it zooms in, and then you activate the electrode, and it actually goes through the vein, through the arterial wall, and then hits the ceramic backstop. And you can see it activate right now. Then we remove the venous catheter, and that's going to come out here momentarily, and then the arterial catheter. And then you can then see the flow. So have an endovascular AV fistula created, which then flows from the deep system, ulnar-ulnar or radial-radial, to the superficial system via the perforator. So in the US, it's concomitant ulnar artery to ulnar vein or radial artery to radial vein, and we want those vessels to be 2 millimeters in diameter. Really what this allows us is to expand our anatomic options for for AV fistula creation. So instead of going from the radiocephalic directly to the brachiocephalic, there is a portion in between. Also, we have a number of patients that are very hesitant to have surgery for some reason or just simply won't undergo it. So this expands our options for creating fistulas in these patients. Here's the system itself. So catheter on top here, you can see this is the arterial catheter. This has a ceramic backstop. And then here's the radiofrequency electrode, and that's what gets activated and actually makes the fistula for us. There's 30 magnets on each side, and that's what allow the magnets to join together. And they're 1 millimeter by 1 millimeter by 1 millimeter in diameter. Goes through a slender sheath, so it's a 4 French system. It goes through a 4-5 slender sheath or just a regular 5 French sheath. Also, because they're rapid exchange catheters. So here's a zoomed up view of the venous catheter, and you can see this coming out there. That's the rapid exchange rotational indicator that allows us to know that we're in correct alignment. And here's the arterial catheter. There's actually 2 rotational indicators, so one at the distal end and then one right here as well. That's also true on the venous catheter. So when you know these rotational indicators are nice and clear, like a knife's edge, then you know that the catheters are in correct alignment with each other. Of course, the magnets are cubed, which then allows them to really line up nicely. You can see over here. So as they come into interaction with each other, you get this really nice alignment between the two, and then allows you to then activate and create your fistula. Quick anatomy review. This is one of the things I've really enjoyed the most about this, is really getting to relearn the anatomy and think about it, a lot of areas that I hadn't really thought about before. So, of course, everyone knows the brachial artery comes down and then gives off the radial artery. But this artery here, I'd like everyone to focus on that. That's the ulnar artery. But most of us, when we hear ulnar artery, think of it at the wrist. This is very large artery. I would refer to it as the common ulnar artery, and this is the proper ulnar artery once interosseous comes off. The vast majority of the fistulas with the Wavelinq have been created in this location. Now, can they be created on the radial end? Yes, they can as well. But the one thing we see about this is a very large vessel, and in fact, a lot of times if you cover up the radial artery, it's hard to tell the difference between the brachial artery above and below its takeoff. Very large vessel. Also, the ulnar veins here have very good communication between them, so whether we create the fistula on the lateral side or the medial side, it tends to work very well. One pearl I want everyone to take home with them is the perforator comes down, goes through the radial, and joins the lateral ulnar vein almost exclusively. So I want everyone to remember that. That's a good tip from the anatomy, something that we've learned now by really studying this extensively. Here we are, kind of a diagram of bringing the wires into positions. Here are 2 catheters. So this is the arterial catheter and then the venous catheter. Prior to activation, remove the wires, activate, and then here's your fistula that's been created. Flow goes across from the ulnar artery to the lateral ulnar vein, then up and out the perforator to the cephalic vein and then median cubital. Of course, then we would place a coil here to increase the resistance in the deep system to force flow out the superficial system. There's a diagrammatic view of it also. As I mentioned, it can also be created on the radial side. One of the things you notice about the radial side is it tends to be smaller. We get better flows when we use a bigger artery, bigger vein, better perforator, better fistula in general. So most of them have been created on the ulnar side, but you can create them on the radial side as well. So this is a diagram, and then the matching arteriogram after creation. So we inject through the artery, and it comes down here, and then you can see it filling across this anastomosis. One of my German colleagues, Dr. Tobias Stenke, shout out to him, he coined it the jelly bean. So he calls this the jelly bean. So that's where you see that anastomosis. The blood then comes over up the lateral ulnar vein, and then the perforator to the superficial system, and that looks really nice there. You can see, even though it's created on the lateral ulnar side, you see filling of this medial ulnar vein. Once again, I mentioned that there's very good communication between the two. So this is a very nice example of what it looks like. Patient selection, procedure planning. What's the screening for this? Well, we could talk an entire session on this, but the basics are they have to be a surgical fistula candidate, meaning you need a cephalic or median cubital / basilic vein that's 2.5 millimeters in diameter or greater. You need a perforator that's 2 millimeters or greater. And then at the creation zone, the ulnar artery, ulnar vein, or radial artery, radial vein need to be 2 millimeters as well. Of course, then you need adequate arterial inflow and that sort of thing. But those are really the key. So superficial 2.5, perforator 2, and then connection site also of 2. So fairly simple to do. And of course, this shows the two sites of anastomosis that are most common, radial, radial, or ulnar, ulnar. And you want to get these as close to the perforator as possible because, of course, the flow is being driven from the deep system to the superficial system. One advantage of the 4 French system is the multiple sites of access. So being able to not only come from the brachial vein above, but being also able to come from the radial or ulnar veins. In the United States, the FDA only has it approved for brachial artery access, although in Europe, many of the physicians that are friends of mine are using the radial or ulnar arteries for their arterial access outside the US. Kind of we can come in this similar direction, we call the parallel approach, or an anti-parallel where one's coming from above and one's coming from below. And like I said, in the US, we only have brachial artery indications, but in other parts of the world, they're doing it either venous from above, arterial from below, or vice versa. Actual procedure itself, get the room set up. Really the key to this, and I think the key with many of these is the access, right? So the ultrasound guided access in the vessel is really key. The easier the access goes, the better the case goes in general. And sometimes you're accessing a little bit smaller vessels in general. So ultrasound skills are extremely important. And then wire navigation to the site, device alignment, the devices, we want them lined up nicely in parallel. And then after creation, here's a nice picture of that, a rendering of it. So you can see the artery coming down, the endofistula, and this is actually on the medial side, and you can see it filling up and over the perforator up to the superficial system. Supplies-wise, the only thing a little bit different is this is done over an 0.14 wire, so 0.014 inch wire. I like the nitrix one, it works really well. The nice thing about these, or the best part to have for these would be short wires. So there's an 80 centimeter one that works quite well, and also kind of a shorter catheter because the working distance, you're just coming from the wrist or above. It's a very short distance that you're actually coming in order to perform the procedure. This is a room setup. So of course, patient's head, arm board, C-arm, and an ultrasound. Fairly basic setup. And this is a very nice arm board that really holds the patient's arm down nicely and allows you to perform the procedure. Here's the arm board itself. And what it does is it really, first of all, hyperextends the arm a bit, and then also externally rotates it. And this then allows us to kind of draw out the anatomy that we were discussing earlier, so you can really see that nicely. I think that's quite helpful as well to have that. And the other thing we use is a tourniquet. I mentioned the importance of access, and so you can see the radial veins here are quite small, but once either we inflate a cuff or put just a standard tourniquet that you'd use for starting an IV, you get much better distension of the veins, which makes them easier to access. And once again, the access is really the key to the procedure, because after that, get the wires lined up, activate, and you have your fistula. If you're coming from above, from the brachial vein, the one thing you do need to know is you'll be working against the valves. There's what we call a V18 wire, a 0.018 inch wire that does very well for that. You just have to work across the valves, which which after a little bit of practice is really not that difficult. The one thing I tell people with that is working against the valves, just be a little bit more gentle than you would for maybe, crossing a blockage in one of the leg arteries for peripheral vascular disease. Want to be a little bit more gentle than you would be with that. Also making sure they don't have central venous stenosis. As far as accessing the vessels on the upper arm, either the artery or the vein, one of the key things I want everyone to just have an eye for, and this is something I think most of you, of course, already know, but what the median nerve looks like under ultrasound. So, of course, accessing this, you would want to avoid the median nerve and avoid a hematoma afterwards. We don't want any compression of that nerve. And then, of course, here's our arteriogram coming down. There's the brachial artery, then becomes this common ulnar artery, and then the proper ulnar artery. You can see if I put my pointer over the radial artery, it almost looks about the same size above and below, maybe a little bit smaller, 80 or 90%, but this is a very good size vessel. And then here's kind of a video of the navigation of the wire. You can see you want the wires in parallel, so the wire crosses, so back up and then bring our catheter in position. Developing a little hoop there. So get the catheter down, advance that a little bit more. And this is the medial ulnar vein. The wire above is in the artery. And it's kind of nice having the wire there in the artery. It almost acts like a road map. And then you can advance your catheter down, see the catheter come in position, back up, and then once it kind of reaches this point, it really tends to go down the arm. So that way then you're lined up and ready to go. What are we looking for once the catheters are in position? Couple things. These rotational indicators we talked about, want to have it so you're like looking at the knife's edge of it, and then of course the separation between the catheters of less than 1 millimeter. Remember, you can use the magnets themselves as your reference because they're 1 millimeter by 1 millimeter by 1 millimeter. So this way you can make sure that you know what the distance between the two of them is. Once again, the electrode, as you move the arterial catheter back and forth, you see a little mild compression of it, knowing that you're in the correct location. You check all these, of course, before activating or before firing it, just to make sure we're in good position. The Bovi itself is 60 watts for 0.7 seconds. It's a preset. You press and hold down the yellow button, very simple, activates and then turns itself off for you. And so then actual fistula creation, we make sure we remove the wires. We make sure that the tourniquet's down. Frequently, we'll use 2,000 to 3,000 units of heparin through the sheath. Some of my colleagues just use heparinized saline or saline itself, just frequent flushes before activation. Rarely use nitroglycerin, only if there's significant vasospasm. So here's it activating, so you can see that here. Here's the electrode, and it activates, and then there's no further tissue between these two. So it activates, that looks great. So of course there's a space between them before because that's where the vessels are. After activation, there's no more space. So the completion of the cut. And then you can see here are two arteriograms, one showing a radial access and one showing an ulnar. And we'll show over here the ulnar creation. See they're injecting through the artery. It's coming down, going across the endoav fistula, across to the vein, and then up and out, okay? If you're looking at these saying, oh my gosh, what is he pointing out? These look, you know, like a Medusa's head coming out. That's very normal at first, and you'll definitely get these down after looking at them for a while. So you can see over here, artery coming down, and then across, then up and out the perforator, out the cephalic vein. Both these look really nice. Here you can see the coil in place over here, and this is before they've coiled it over there. So both of those look really nice. The one thing we do get an occasional question about is what about calcification? Can you still do it if there's calcification? The answer is yes, you can. Now, if it's extensively calcified, like here where you see complete shadowing of the artery, this may not be a good one to do with because it won't chisel through rock, it more vaporizes the tissue. Then afterwards, placing a coil. Usually we just do pushable coils, Nestor ones, 6 millimeters in diameter would be fine. This one just happens to be showing an Amplatzer, but any coil of any kind, essentially what you're doing is you're increasing the resistance in the deep system because you want the flow to go superficial. And then of course afterwards holding hemostasis and making sure you don't have any bleeding, and also done at the wrist if you've accessed there as well. Here's a quick case we're going to run through. So here we're going to do brachial artery and ulnar vein access, anti-parallel. Here's the arteriogram, so the artery coming down, the common ulnar artery, of course the radial up here, labeled ulnar artery and radial artery. This is a left arm. Here the vein is accessed at the wrist, and you can see the wire coming here, and then it's crossing into the lateral ulnar vein. Remember, I said to remember the lateral ulnar vein is the one that joins the perforator. So there it is right there. Beautiful example of that. You can see how robustly that's filling up there. Ulnar vein, and then of course the wires in the artery. Brought the two catheters into position, and then there's activation. And then of course, kind of after activation, boom. So you can see injecting via the artery, blood flow coming down, across to the lateral ulnar, and up and out the perforator to the superficial system. Fistula is created. That looks great. And then a coil is placed. There's a coil there, and you can see good flow up and out here. So getting the access is the key, then getting the wires in position, bringing your catheters in place, and then activating, then having your fistula. So why do an endovascular fistula? Well, the idea behind this came from Billy Cohen, one of the cardiovascular surgeons in Houston, who made the observation that traumatic AV fistulas from gunshot wounds or stab wounds when he was working in the ER, for some reason were very difficult to close down. They tended to stay open. But surgical ones would close. We struggled to keep them open. So the idea was to create this kind of fistula between the artery and the vein with just a simple cut. So there's no welding, there's no gluing, there's none of that. There's just simply a cut between the two. People ask, well then, why doesn't it just bleed? How does that stay close together? And the surgeons will tell you that the artery and the vein are very well connected, and actually takes a fair amount of work, dissection, to get them off. So it's those natural connections that actually hold them together. And then over time you get this endothelial development and heal that in place. And so here it is in one of the ovine models of what it looks like. The anastomosis is 1 millimeter wide by 5 millimeters long. That's the end of AV fistula anastomosis. The other idea behind it is that the flow volumes tend to stay very consistent. So they tend to not go much above a liter. So you don't have this very high pressure fistula. Idea behind it would be that you have lower kind of rates of aneurysmal development, or maybe cephalic arch stenosis over time, that you don't have that significant transmission of pressure from the anastomosis to above, because it's really a side-to-side anastomosis, and then of course then the flow being directed out multiple channels. As far as for follow-up, we're looking for flow volumes coming in. We'd like somewhere around 800 or 900, and then of course the flow in the cephalic vein itself or the median cubital. This is an example of after creation. One thing you notice is no incision. And so here you can see nice flow in the median cubital as well in the cephalic, and you can access down here beyond the elbow crease or higher up on the arm as well. Very similar to what we would mention as the Gratz type fistula, where you use the perforator and sew it down to the artery. It gives you a split outflow versus the single outflow types of ones. Here's kind of the multiple varieties of cannulations that can be done. Here's two needles in the upper arm cephalic, similar to a brachiocephalic. Here using the upper arm cephalic, and then of course distal to the elbow crease. And then here we are using the cephalic and then median cubital. And then this one is a basilic dominant one. So here's median cubital and then the basilic itself. If someone has a thinner arm, that's definitely possible. We have, of course, a large amount of obesity in the United States, and so sometimes we do have to elevate these for patients with deeper veins. This is from the NEAT trial. So here's the brachial artery flow. If you're looking for a nice paper to discuss, maybe for a journal club, or to kind of see what got this up and running, the NEAT trial is very good. You can look on Google Docs for that one. And so you can see kind of where these, like I mentioned, kind of peaks at around 800, 900 a liter of flow. Then of course, then vein diameters as well. And it gives you more usable vein length. Of course, since the anastomosis is deep, you can access near the, or distal to the elbow crease, unlike with the surgical fistula, we have to stay away from that incision site. And then as far as kind of post-interventions, things that are needed, sometimes angioplasty is required, particularly of the vein just above the anastomotic site. Sometimes you can need to angioplasty that to increase flow, because you still are creating an anastomosis of an artery, high pressure, to a vein, low pressure. You can have that. Other times you do need to do further coiling of the deep system to help flow out the superficial system. I wouldn't say necessarily it's necessary in all procedures. It's not necessarily that common, but those are the types of things when people ask what needs to be done. So I really want to thank Avatar India for having me. Like I said, I wish I was there with you guys. I'd love to come see your country at some point. The Wavelinq system, I think the key points are understanding the anatomy. So it's the deep system, the superficial via the perforator. It's a 4 French system. It gives a lot of versatility of where you can access from. It's radial artery to radial vein, or ulnar artery to ulnar vein, and then a coiling to drive the flow up and out. Usual maturation is somewhere around 6 weeks for the fistula, then they can be used. You can't intervene on them afterwards if you need to, and you have a nice anastomosis that's very precise each time, 1 millimeter wide by 5 millimeters long. So with that being said, thank you so much for your attention and look forward to hearing from you in the future.